Hello, everyone. Today, we're going to explore an important question in the management of acute myocardial infarction, or MI. For decades, beta blockers have been a cornerstone in post-MI care, recommended to reduce the risk of further heart attacks and mortality. However, recent studies, including the REDUCE-AME trial published in 2024, have started to challenge some of our assumptions about beta blockers, particularly in patients with preserved ejection fraction after MI. Today, we'll delve into the clinical findings of this trial, its impact, and what it might mean for the future of post-MI treatment. Clinical question. Our focus question today is, among adults with an acute MI, does the use of beta blockers reduce the likelihood of recurrent MI or all-cause mortality when compared to no beta blocker use? This is the fundamental question that the REDUCE-AME trial aimed to answer. Bottom line. To summarize the main takeaway, in adults with acute MI, beta blocker use does not significantly lower the risk of MI recurrence or all-cause mortality compared to those not using beta blockers. This finding prompts us to reconsider routine beta blocker use in certain post-MI patients. Background. Historically, beta blockers have been an integral part of post-MI care guidelines. For instance, the 2013 ACF-AHA STEMI guidelines recommended beta blockers at discharge with a strong evidence rating. A 2021 Cochrane review echoed this, suggesting beta blockers might reduce all-cause death and recurrent MI, though it noted a gap in studies for patients without left ventricular dysfunction. The REDUCE-AME trial, therefore, fills an important knowledge gap, especially concerning those with preserved ejection fraction. Introduction to REDUCE-AME trial. The REDUCE-AME trial, also known as REDUCE-SWEETHEART, was conducted with the primary aim of assessing the impact of beta blockers in post-MI patients with an ejection fraction of 50% or greater. This large-scale trial randomized 5,120 patients from Sweden, Estonia, and New Zealand, comparing outcomes for those on beta blockers to those using them. Trial design. The trial employed a registry-based, prospective, open-label, randomized controlled design. Patients were enrolled across 45 centers and were followed until late 2023. The primary outcome measured was a combined endpoint of MI or all-cause mortality, making it directly relevant to our clinical question. Population. To better understand the study's scope, let's look at the inclusion and exclusion criteria. Eligible participants were adults aged 18 and older who had experienced an MI within the past week, had undergone angiography with obstructive coronary disease findings, and demonstrated preserved ejection fraction post-MI. Exclusion criteria included contraindications to beta blockers or specific indications requiring their use. Baseline characteristics. In the beta blocker group, the average age was 65 years, with a predominance of male patients, 78%, and a mostly Swedish cohort. Common cardiovascular risk factors included hypertension, which was present in nearly half of the participants, along with smoking and diabetes. About 25% of the participants had presented with STEMI, and 97% had reported chest pain as a primary symptom. Intervention groups. Participants were randomized into two main groups. The beta blocker group, where most patients received metoprolol, initiated during hospitalization and continued post-discharge. The no beta blocker group, where beta blocker use was discouraged. For those on beta blockers before admission, a tapering protocol was followed over 2 to 4 weeks. Outcomes. Primary endpoint. The primary outcome, a composite of MI recurrence or all-cause mortality, showed no statistically significant difference between the groups. In the beta blocker group, 7.9% experienced the primary outcome compared to 8.3% in the non-beta blocker group, with a hazard ratio of 0.96 and a p-value of 0.64, indicating no clear advantage of beta blocker use in this patient population. Outcomes, secondary endpoints. Examining secondary outcomes also revealed minimal differences. All-cause mortality was nearly identical between groups at around 4%. Cardiovascular mortality was slightly higher in the beta blocker group, but without statistical significance. Recurrent MI and AF hospitalizations also showed negligible differences, with all outcomes supporting the primary finding. Adverse events. Adverse events were similar across both groups. Hospitalizations for conditions like bradycardia or hypotension occurred in 3.4% of beta blocker users compared to 3.2% in non-users. Rates of asthma and COPD hospitalizations were equal, and stroke hospitalizations were also balanced between groups. Criticisms and limitations. While the REDUCE-AMA trial provides valuable insight, several limitations exist. The open-label design could introduce bias. Additionally, using a registry for event tracking may lead to misclassification. One notable omission was a thorough assessment of heart failure hospitalizations, a relevant endpoint for understanding beta blocker impact in preserved EF. Implications for practice. Currently, no new guidelines reflect the findings from the REDUCE-AMA trial. However, the data suggests that beta blockers may not be necessary for post-MI patients with preserved EF, which challenges our traditional prescribing practices. This trial invites further investigation into more tailored post-MI treatments. Conclusion. To summarize, the REDUCE-AMA trial challenges the long-standing belief in beta blockers' benefits for all post-MI patients. For those with preserved ejection fraction, this trial found no significant benefit in using beta blockers to reduce recurrent MI or all-cause mortality. This represents a potentially pivotal shift in how we approach secondary prevention in this patient population.